Today we're talking about headache. Let me know if you can't see it okay or can't hear me properly. My internet does cut off. Okay. And so with today, I'm going to talk to you about 6 main conditions.
Who's giving it?
Migraine, plus the headache. Tension type headache. And with the red flags, hemorrhage. Angle closure for coma. This is what we're going to do today. I figured from last week, because sort of writing down does take some time, so I'm just going to type things out. I think with formatting and just with sort of eligibility, it's probably better for you guys to understand what I'm writing. So just getting the screen out of the way first. So migraine headache. So to understand migraine headache, firstly, let's sort of talk about some vascular changes, so sort of the pathogenesis first. So it's basically changes to the vascular tone and specifically to the sort of the cranial vessels and sort of disruptions to the neurotransmitters, specifically serotonin and dopamine. And it's important when you're suspecting migraine headaches to ask about the triggers. And the triggers include red wine, so the high tiring foods as well, like cheese and chocolate, fasting state, lead to migraine, stress in life, menses, and OCPs. And some aggravating factors, which can also be considered as triggers sometimes, are bright light, and I should probably put it all under triggers. Yeah. And another thing is sleep deprivation. And let's do a case-based scenario. So case 1, woman in her 20s presents with described as throbbing headache. Usually it lasts for greater than 2 hours and less than 24 hours is the typical presentation. And associated with, because some people have said to me that the association factors is sometimes pretty difficult, and I'm just going to focus on the associated factors today. So for your OSCEs, it will probably help you when sort of determining what sort of headache it is. So for migraine headache, it's associated with pretty non-specific nausea and vomiting, photophobia, and okay, and it's relieved usually with sleep and darkness. So a lot of people say a definitive sort of marking for migraine is actually the aura that's present, but migraines can occur with or without auras. And the classic presentation is unilateral pulsating headache. If there is aura, it is often a visual aura preceded. And a good word to use is scintillating scopomas, which basically just means bright or flashing lights, and visual field cuts. Okay. Sorry about my dog. And the diagnosis is usually a clinical diagnosis based on history, and usually it can also be a diagnosis of exclusion once you run investigations and they all come back negative. And let's just focus on some management aspect. So first of all, as with all headaches, you identify the trigger and avoid known triggers and try to reverse that if possible. Secondly, which is your abortive therapy, which may include triptans. So sumatriptan is usually the agent of choice that is used. And I've seen a couple of cases where sumatriptan is actually combined with calcium channel blockers, and it tends to have a very good effect. And that's often prescribed after over-the-counter sort of NSAIDs have failed. The ibuprofen doesn't sort of relieve the headache, then you move to the triptans. And I was told by a neurologist that apparently triptans help with acute attacks. So you want to sort of use it during your episodes of flare of the migraine headaches rather than as a maintenance. So we can either use it alone or with another analgesic or plus other analgesic. Okay. And what's important also is your prophylaxis. And prophylaxis for severe migraines or frequent severe migraines include anticonvulsants. And that can be, for example, gabapentin, topiramate, or your TCAs or tricyclics, for example, amitriptylines. And you can also use beta blockers as propranolol with a long-acting half-life. And as I've discussed before, you can add in a calcium channel blocker. So to fully eliminate the acute flare of headache, you usually use triptans along with other analgesics, but for prophylaxis for frequent and severe migraines, you sort of want them on anticonvulsants such as topiramate or tetracycline, such as amitriptyline. I spelled it wrong here. Beta blockers such as propranolol and calcium channel blockers such as nimodipine. So I think that's the high yield stuff for migraine. Are there any questions?
Just want to ask, this may seem like a peripheral thing to ask, but are there particular risk factors or genetics involved in, like, I guess, migraines and stuff?
It tends to run in families, yes. However, specific gene, no. I would say it's a polygenetic thing that has a sort of a condition with a sort of genetic predisposition. So if that answers your question, Alex. Any other questions?
I guess a more OSCE focused one would be like, what in your kind of personal experience would be relevant differentials to consider with migraine headaches?
Yeah, I'll get to that. Okay.
All right, cool.
So as I said, today it'll probably be a brief approach to how to approach headache in your OSCEs, and then I'll sort of focus a bit on management side of things, because I think we tend to sort of ignore it or not focus too much on the management aspect. But to answer your question in short, so migraines, I think about seizures, I think about cluster headaches, I think about tension type headaches, and those are sort of more common. However, red flags, I always structure my answer as if what's the most prevalent, the most common, moving to what's the most dangerous. So if it's more dangerous, then I look to subarachnoid hemorrhage, I look to cavernous sinus thrombosis, I look to stroke, I look to acute angle closure glaucoma, and I look for specific signs associated with each. Let me see in the chat. Yeah, GCA. We'll talk about GCA if we have time as well. Actually, we will talk about GCA when we talk about the secondary headaches. So with migraine cluster and tension type, they're all primary headaches. With secondary headaches, we do look for things such as increased intracranial pressure. And for that specifically, I'll give you sort of my approach to how to ask questions and how to sort of differentiate between the different symptoms. So, getting the page up. So cluster headache. Can anyone tell me if men or women are more affected with cluster headache? So I can't see the chat, so just maybe unmute yourself.
So you said men?
Yeah. And does anyone know the average age of onset? It's about around 25. So let's do our case 2. And sort of taking Alex's advice from last session, I'm trying to sort of provide you some cases just to get you thinking. So maybe a 25-year-old medical student sort of wakes up from headache, not because of the exams, but because of unilateral periorbital pain that's associated with ipsilateral lacrimation. Okay. Obviously, he or she may not tell. He in this case will not tell you that history specifically. So you got to dig for lacrimations, salivations. You got to dig for the site of the headache, the severity of the headache, and in that case, you would want to think about cluster headache. So it can be excruciating pain. For migraines, patients tend to be not so bad. However, cluster headache is very debilitating and people can be quite frank about it. It's usually periorbital, as we've discussed in the scenario, and with the time frame, it usually lasts around 30 minutes to about 3 hours. So obviously, if you have someone who presents with sort of a 2-minute intermittent headache, it's unlikely to be a cluster because it does sort of go for a longer period of time. And during that period of time, patients is pretty irritable, they're very restless, they can't really go back to sleep. In fact, they actually wake up from the pain, and that's the usual sort of presentation that you get. And as the name suggests, it tends to occur in clusters. So that's... Alex, can you admit that person?
Yeah, it's all settled.
Okay, occurring in clusters, and it tends to actually affect the same part of the head at the same time of the day. So this is pretty important. Occur similar part of head at similar points of time of the day. Sorry about my loud typing. And it usually occurs during sleep. That's usually the time of the day I'm talking about. And it's often during a certain time of the season of the year as well. So people may get it during winter, people may get it during summer. And associated features, as I've said, ipsilateral lacrimation is something that you get of the eye. You can get, I'll just put it under the case as well, conjunctival injection. So it's basically if you roll your eyelid down, especially the lower one down, you can see sort of injections into those, and you can get something called a Horner's syndrome. What are the three aspects of Horner's syndrome?
Ptosis.
Mm-hmm. That's one. What changes do you get in the pupil?
T said meiosis and hydrosis for the other two.
Yeah, very good. So, and does anyone know why Horner syndrome occur?
T says compression of the sympathetic ganglion.
Yeah, whereabouts is the ganglion? All right, that's probably extending you a bit. So Horner syndrome can occur with carotid dissections. In that case, sympathetic ganglion around C1, C2 can be affected. However, in this case, it's more with cluster headaches, it's more a cranial problem rather than a spinal problem. And Horner syndrome affecting the sympathetic sort of pathway, it can occur at any point ascending towards the cerebral cortex. And usually with Horner syndrome, with pathologies such as Wallenberg syndrome, so lateral medullary syndrome, it occurs at the level of the lateral medulla. But I don't think you need to know that. Anyways, and you can get nasal stuffiness too. Okay. Are there any questions on history and presenting complaints of cluster headache? So with the diagnosis, it's once again, similar to migraine. We usually diagnose it on the history of repeated attacks over sort of an extended period of time. It's unlikely that we diagnose someone of cluster syndrome cluster headache if they come in first time complaining of acute headache. Usually those episodes require sort of more investigations such as MRI, carotid artery ultrasounds to exclude sort of either a space occupying lesion or other disorders which may cause Horner syndrome like we've discussed. For example, a carotid artery dissection, or we'll talk about later, a cavernous sinus infection which leads to thrombosis. Okay. And let's do the management. So management, I group it into acute and non-acute. So with acute, does anyone have any ideas of how we manage cluster headache acute?
T says high flow oxygen.
Yeah, high flow O2 is one. We can also use sumatriptans. So triptans, just as how we manage the migraine headaches. And with prophylactic therapy, Anyone know?
T says verapamil.
Yeah, so calcium channel blockers are usually used. And alternatively, we can use lithium, which is, sorry, lithium is not a calcium channel blocker. We can use lithium. We can use anticonvulsants like sodium valproate, and also topiramate as well. So you can see sort of a similar overlap with the migraine headaches as well. And that's pretty much it for cluster. Any questions on cluster headaches? Yeah, we'll move on. Move on to the most sort of, I would say the most frequent type, and sort of I get it all the time for sure. Tension type headache. It's a very benign headache, so you don't really have to worry about it. And sort of the case that I'm going to tell you is 46-year-old office worker presents with light and like pain. That is worse with stress. Okay, this is a typical presentation. Office worker sort of sitting in front of a desk all day, coming with band-like headache all over the head. Difficulty sleeping, poor concentration, anxiety can all be associated with these types of headache. And actually usually occurs towards the end of the day. Okay, and those people may often have sleep problems, irritability. So you got to delve further into their social history, what they do for work. So that's sort of important to establish quite early on, and to sort of identify the triggers and the aggravating factors for the tension type headache. And in terms of diagnosis, with the clinical diagnosis, you usually have to have more than 2 of the following few factors. One is bilateral location. We know it's usually both sides rather than a unilateral. So you tend to worry about unilateral headaches more. It's usually a pressing or tightening sort of sensation. And the headache is usually mild to moderate intensity. But if they tell you it's the worst headache that they've ever experienced, firstly, establish their pain threshold. But you definitely want to run more investigations to rule out more sinister causes. And it's usually not aggravated by routine physical activity. So if I change the scenario, and if I tell you a patient comes in with new onset headache, which is similar in presentation, however, the patient's over 50 years old, what then do you have to worry about? And
So
let's say,
worried about giant cell arteritis.
yeah, so let's say mild with no associated constitutional symptoms, presenting sort of greater than 50 years old. You always want to check investigations for ESR to rule out this. Okay. what condition is associated with this yet? Alex, do you know?
Like as T said, PMR.
Yeah, so polymyalgia rheumatica. So you can always ask if they got pain and aches over the body as one of your sort of association questions. All right, so treatment, non-pharmacological mostly. So relaxation, massage, and one important thing is actually sleep. So if the patient can't go to bed, for example, you want to establish sort of sleep hygiene for them, make sure they have a good rest at night. If that doesn't work, then you may move to pharmacological, for example, melatonin slow release, 2 milligrams, 2 hours or 1 hour before sleeping, and make sure they avoid exacerbating factors. So if they sort of their headache comes on after stress at work, I know it's difficult with lockdowns, but maybe counsel them, organize sessions with social work to relieve their stress. So they can all be a combination of things that you do and how you formulate your answers for your OSCE. Of course, they can try NSAIDs, paracetamol, and if they all don't work, triptans sometimes be considered as well. All right. So to finish the primary and the more benign causes, I'm going to give you a pop quiz, okay? So 24-year-old woman with 3 weeks history of, let's say, retro-orbital headache, associated with occasional nausea and vomiting, and let's chuck in tinnitus. Has diplopia. Maybe 1 hour prior to headache. And you've noticed some papilledema on examination. What are some further questions that people would like to ask?
Personally, I would like to ask about any falls or especially falls that leads to head trauma.
Yeah, good. What else? I'm going to go through the list. Maybe let's go with Ludi.
Sorry, what was the question?
The question is, based on the case that I've given you, what further questions would you like to ask?
I don't know. Any hearing loss? She has tinnitus.
Yeah, she has tinnitus. Okay, so I'm actually going to, anyone else has any specific questions they're desperate to ask?
Would you ask about dizziness or anything?
Well, nausea, vomiting, dizziness, tinnitus. Yeah, you would ask about dizziness for sure. What's sort of more sinister than dizziness? What's another word that I'm looking for? Dizziness doesn't really bother me. However, if they have something else that's similar to dizziness, then it may be a more sinister cause. Does anyone know what I'm thinking about?
Vertigo.
Vertigo?
Yeah, very good. Vertigo. If they have vertigo, then I would maybe do a hints exam to see whether sort of the vertigo is from a central or a more peripheral cause, and that can explain the tinnitus as well. But we can have a separate seminar on the approach to vertigo. Any other questions that people want to ask?
Personally, I would also ask about any chance you may have gotten pregnant or you plan for pregnancy.
Yeah, very good. So any woman of childbearing age, you want to ask about pregnancy or possibility of pregnancy. Very good, Alex. So we will leave it here, but we'll come back to this example after we've talked more about the more sinister headaches, okay?
T also mentioned about asking about MS as well.
MS, multiple sclerosis. Okay, what's making you think about multiple sclerosis, T?
His mic is currently not working, so I'm kind of dictating for him. So he says, like, given the young female with visual changes as, I guess, the clinical profile.
Yeah, sure. Yeah, possible. So optic neuritis from the retroorbital headache might be a possibility. Diplopia if they have interruption to their medial lemniscus fasciculus, so MLF can be a possibility here. So yeah, possible MS differential as well. Anyone else? So in your OSCEs, when you have a headache history, the money is actually in the associated features. So you got to ask about a series of questions in your associated features to rule out all the red flags. So how I approach it is I think about I think about a few things. Firstly, fever or rash. What am I thinking with fever or rash?
Meningitis?
Yeah, meningitis. Do you know which one specifically that causes rash?
Bacterial?
Yeah, bacterial, more specifically Neisseria meningitis, with the meningococcal rash in the legs, more specifically. And don't forget, sort of virus can cause fevers or rash as well, so viral meningitis as well. And other infective causes. And then I want to ask about jaw claudication. And I'm sure you know by now, it's temporal arteritis or your GCA. And also, I want to ask about weight loss. Why do I want to ask about weight loss?
Malignancy?
Yeah, so neuroplastic. So inflammatory, infectious conditions, okay? So if the person has a intracranial abscess, for example, they can have weight loss or wasting. If they have space occupying lesion, they can have weight loss as well. And then I move on to my combination questions of, does the patient have any photophobia, nausea and vomiting, neck stiffness. Okay, and the two differentials here that I'm getting at is firstly my subarachnoid hemorrhage, and next is meningitis.
Yeah,
got that wrong, but you get typing. Okay. What else do you want to ask for?
T is also considering asking questions with regards to idiopathic intracranial hypertension.
Very good, T. And what specific question would you ask about idiopathic intracranial hypertension, or the name for is pseudotuberous cerebri? So it is in fact the answer to this particular case. It's actually idiopathic intracranial hypertension. And one important question to ask about this woman is, how much does she weigh? Or on physical examination, you would want to look at her and see whether they've got any risk factors. So questions you would ask for in idiopathic intracranial hypertension is, first of all, obesity. The old name is tumor cerebri. And the reason is because idiopathic intracranial hypertension actually presents with all signs and symptoms of increased ICP. However, on brain scans or brain MRI, they actually don't have a space-occupying lesion. So the questions you would ask is obesity. If their BMI is 20 versus if it's 35, would make you think differently about this diagnosis. Whether they're on tetracyclines, whether they're on growth hormones, or whether they have any excessive vitamin A intake, okay? So those questions you would ask for risk factors for IIH. So coming back to this. Any other stuff you want to ask about? So after sort of going through my questions, there's one major category that I'm missing here. Whether there's any increase in ICP. How would I ask those questions?
Like you would ask the patient if they feel like there's a pressure building up inside their head?
That's usually not the presentation, Alex.
Okay.
Yeah, that patients don't usually feel that. So one important thing is to ask about cough. And anyone know why?
Oh, is it because of like the whole cough tree, the whole Valsalva thing?
Yeah, it's to do with Valsalva. Basically, it's to do with pressure as well. Yeah, I will explain it later during the talk. Don't worry. It's nocturnal headache. Okay, and headache that wakes patient up. Morning vomiting. So why do people vomit? And why do people feel better after they vomit? It's a similar idea to cough. So basically, anyone want to have a go?
So I guess similarly, the body's trying to get rid of that built up pressure.
Yeah, basically when you're doing a Valsalva or when you're vomiting, you are sort of pushing out air. That's how I think about it. So you're basically pushing out carbon dioxide. And with a decrease in carbon dioxide, it actually leads to cerebral vasoconstriction. And as a result, you actually decrease your ICP. So if the headache do get better with coughing and vomiting, it is a worrying sign, and you should always do a scan, CT non-contrast, to see if there's any space-occupying lesion. And similar with back pain, age is important. So onset of age greater than 50-year-old. And of course, focal neurological signs. And on examination, what do you find with that would worry you? Diplopia. Usually it's one of the first signs that you would want to detect. So cranial nerve 3 palsies, cranial nerve 6 palsies can all lead to diplopia. So you want to do a cranial exam for them, focusing on the eye. And why cranial 6? Because it travels in the middle of the cavernous sinus. So if you have an increase in intracranial pressure, it's the first cranial nerve to give as a result of compression. And that's usually called a false localizing sign. So you also want to assess their mental status to see if there's any changes in cognition. So for example, with butterfly gliomas, you can get cognitive changes if they're crossing both bilateral frontal cortex. And you want to assess for numbness, weakness, dizziness, ataxia, visual disturbance, and one that is important. So fundoscopy. You want to assess for papilledema, what stage of papilledema, whether you can still see the cup, whether the cup is increased based on your fundoscopy examination, so increased cup to disc ratio, and you want to see whether your retinal vessels are still clear in view. Okay, so what investigations would you then go forward and perform with the more sinister headache, that is?
Head CT?
Yeah, with or without contrast?
Without?
So you always do one without contrast first, and then if you detect a mass, then you can move on with gadolinium.
Okay.
And then what else?
I'd like to say MRI, but that's always the more expensive choice.
Yeah, that's right. Does anyone know how long an MRI brain full spine lasts for? As in the time that the patient has to sit in or lie down in that machine for to get a whole MRI brain and spine?
T says 1 hour approximately.
Yeah, so it's about 1.5 hours in the MRI machine. So you really want to establish if there is a space occupying lesion before sort of moving to the MRI. Even with space occupying lesion in the spine, you always want to be certain that there is some abnormality, even with MS. So I would say structure your investigations in a way that is succinct and structured. So how I would go about sort of answering investigation questions is that I would start off with the bedside. And this is with all presentations, so not specific to headache. So I would think that if the patient, does the patient need any bedside investigation? So by bedside, I mean whether they need a urine dipstick, whether they need a urine MCS, for example. But urine MCS is more moving to the lab, the lab aspect of investigations. And then I would want to ask if the patient needs an ECG, but not specific for this presentation, of course, but it's just the way to structure answers. So moving on from bedside, I might want to do some basic bloods. Always ask for a full blood count. And the reason is because you always want to assess if there's leukocytosis, if the patient is anemic, if they have increased platelets, signifying maybe an acute inflammatory process, or if they are low in platelets, maybe a consumptive order or intravascular hemolysis, for example, or sort of platelet dysfunction syndromes, for example. Sort of your rare hematological conditions, which can cause pancytopenia. So you always want a full blood count as your base, as your base, to compare to later on if the patient do need sort of a bed inpatient to become an inpatient. Then I would often move to a UEC to get a. Well, why do I need a UEC here, Alex?
You want to, I guess you want to see kidney function, but I guess would you also be concerned about like like a UTI linked to potential delirium as well, or is that too far-fetched for this kind of scenario?
Yeah. So remember we said head CT without contrast, but if we want to add in contrast, we always want to assess for kidney function.
Oh yeah, true.
So we always want a UEC, and also we want to see if there's any electrolyte disturbance. Does anyone know a particular condition of electrolyte disturbance that may cause headache? Actually, there are two that I can think of. Actually, three, but two more commonly.
Maybe sodium.
High sodium or low sodium?
I'm thinking low sodium.
Yeah, very good, Ray. So low sodium and also hypercalcemia can cause headaches too. Low sodium specifically because of the fluid shift, you can have some cerebral edema as a result of low sodium, but usually they become symptomatic once the sodium hits below 125 milliosmolar. So in that case, you then follow up with, does anyone know what you follow up with if you're suspecting hyponatremia?
Like hyperkalemia?
No. If you're suspecting hyponatremia, what would you then follow up with? What investigations would you run for hyponatremia? So you would want to do a serum and urinary osmolality.
Oh right, yeah.
To assess, first of all, whether there's any syndrome of inappropriate ADH production. You want to see whether the ADH is sort of physiologically appropriate for that particular patient. You would assess the fluid status to see if it's hypovolemic, euvolemic, or hypervolemic hyponatremia. And then you would want to obviously go to do other electrolytes as well to see if it's metabolic alkalosis-led hyponatremia or hypochloremic hyponatremia. Well, we can do that as a separate talk another day. Anyways, so head CT without contrast. So I'm only writing down sort of the specific one that's very high yield for the headache presentation, but you should always structure your investigation. So moving on from bedside to basic bloods. And for headache specifically, you would also want to obtain an ESR with the giant cell arteritis that we've discussed. Any other blood tests that people can think of?
I guess this is unrelated to headache specifically, but I guess in a young female, you might do a beta HCG. It could be a urine or blood, depending. Yeah.
Yeah, very good. Beta is very good, right? Yeah, and that's pretty much all I can think of in terms of blood that's needed specifically for headache presentation. And then after your basic bloods, then you move on to imaging. So head CT without contrast first, then moving on to MRI if you find something in the CT, that is, or if you're suspecting more subtle changes to the brain. Can anyone think of some conditions which may lead to headache but cannot have any positive findings on head CT but positive findings on MRI? Sorry about that long question. So what T3 was getting at first, sort of multiple sclerosis, inflammatory changes, they might be negative findings on CT. However, if you do an MRI, you can see that there is sort of demyelination or plaques, the sclerotic plaques on near the corpus callosum and also in the spine that's separated in space. Okay, so that's something that you can possibly find. And in terms of treatment, we won't delve into the treatment because for each condition, it's probably different. Actually, it is different, but usually you want to settle the patient down with analgesics for pain relief. And if the patient is having increased ICP, does anyone know what sort of initial workup that we need for increased ICP? Any? So if a patient comes in with increased ICP, what would you do on the ward for them before assessed by, say, neurosurgeons?
Do you mean like exams, like clinical exams, or?
No, just management-wise.
Maybe, I'm not too sure, I can't remember properly, but maybe consider withdrawing any medications which might increase their pressure, intracranial pressure.
What medications are you asking specifically?
I'm not too sure. Yeah.
Yeah, so unlikely that medications will increase intracranial pressure, but there are a few things which you need to monitor. Firstly is their blood pressure. Blood pressure is pretty important because I'm sure you're aware of Cushing triad as one of the terminal signs of increased ICP. So if they do get, does anyone know if it's hypotension or hypertension?
Hyper?
Yeah, if they get hypertension, and with sort of your bradycardia, with your irregular breathing, then you do sort of worry a bit. However, you do want to monitor their blood pressure. There's another thing I was going to say, but I forgot. Oh yeah, so in subarachnoid hemorrhage, usually the patient can come in with a blood pressure of, let's say, 220. But we don't want the blood pressure to be that high as a result of prevention of rebleeding, which is pretty common in subarachnoid hemorrhage. In that case, what would you give the patient?
Maybe like something to lower blood pressure, such as a beta blocker.
Yeah, you wouldn't give beta blocker, you would give hydralazine. So hydralazine is used for more acute drop of blood pressure when you don't want that permissive hypertension to go on. And that's sort of your risk of rebleeding. Other things to decrease blood pressure, simple things. Don't think medication, think about simple strategies that we can sort of buy us some time before the neurosurgeons come in.
Do you mean like perhaps instructing the patient to do like breathing?
Not so much breathing, because if they do have increased ICP, first of all, they're going to be pretty drowsy. And second of all, breathing doesn't, if you're hyperventilating, you might not even decrease your carbon dioxide a bit. I'm giving a hint there. So first of all, I would raise the bed up 30 degrees to help drainage of hydrostatic pressure, that first of all. Secondly, I would institute hyperventilation. However, I may need some help with the anaesthetist there. If the patient's pretty unconscious, and I do need permissive hypocarbia. And as we've discussed before, hypocarbia can lead to vasoconstriction in the brain, and that sort of decreases your blood flow to the brain, and therefore decreasing the increased intracranial pressure, because essentially the ICP in the brain is blood, brain, and CSF. So if we decrease blood, we can decrease the increased intracranial pressure. If we get rid of the CSF, we can decrease the ICP. And if we can decrease the brain, which sometimes in desperate times, you do a radical frontal dissection just to decrease ICP as well. And that's it for management of ICP for now. We'll move on to subarachnoid hemorrhage. Does anyone have any questions on the usual history, treatment, and investigation plans for more sinister headaches? Oh, I've got I can see the chat now. There's a question here. Would you give mannitol? Yeah, so in you might not be able to give mannitol just as an intern. However, you can definitely give 1 bag of mannitol to decrease ICP, yes. So hyperosmotic fluid to draw the fluid out. That is an option. Why would you ask about nocturnal head for increased ICP? Okay, so when you're lying down, the venous drainage, or the venous drainage is less, first of all, resulting in more blood volume in the brain. And that can lead to increased ICP, and that can worsen the headache. That's why you asked about nocturnal headache if you're suspecting increased ICP. Does that make sense? No worries. Okay. So let's talk about subarachnoid hemorrhage. Can anyone give me some feedback in terms of, is this useful for you? Is this something that you want? And I do go off tangent a bit, quite a lot actually. So hemorrhage, we should all know by now, thunderclap headache is usually the presentation. But don't forget, they actually get all the meningitic symptoms. So your neck stiffness, your photophobia, your phonophobia, nausea and vomiting, all signs and symptoms that's consistent with meningitis you can get with subarachnoid hemorrhage, because with subarachnoid hemorrhage, it's in the subarachnoid space and it's irritating the meninges. So it's irritating both the pia and the arachnoid membrane. Other signs of meningeal, we've talked about that. Can anyone tell me 2 stretch signs that I look for on examination? One starting with K, one starting with B, that I will look for to see if they've got meningism.
Koenig and Brudzinski.
Yeah, very good. Koenig and Brzezinski. Who was it Ray?
Yeah, that's right. Right.
Sorry, I just can't see the screen for some reason.
All good.
But yeah, can you tell me what Koenig is, what Brzezinski is?
From memory, I think Brudzinski is where you flex a neck, and then that causes an involuntary flexion of the, I believe, the knees. And I believe Koenig's is the other way around. So I believe you flex the thigh, flex the thigh, and then I'm trying to picture it.
Yeah,
but,
very good. Yeah, very good. So both tests require sort of you moving the body part, yeah. And how I remember it is Brzezinski starts with B, is before K. So you move the body part that's further up. So you move the head, as you said. So on passive flexion of the neck, you elicit hip and knee extension. Okay, so that's your Brzezinski as you've described. And Koenig, I think about, because K becomes after B, so it's more distal in the body. So you move the leg essentially, and you elicit pain or limited extension because of pain when you flex the knee to 90 degrees and when you flex the hip to 90 degrees. And the extension of the knee in that position should be painful, and that's when you know that there's some meningeal irritation, and actually it goes all the way to the spine. Does that make sense, anyone? Okay, assuming yes. And do people know why people complain that before the headache they've experienced something similar, sort of days to weeks prior to presentation?
Is it because of vasospasm?
No, vasospasm is actually something that you get after. Because of the blood irritating, sort of the blood in the perivascular space, if you like. So
Maybe it's
leak.
the leak, maybe.
Yeah, very good. It's a leak sort of prior to your bleed. So most often it's because of a Barberry aneurysm, as you well know. So a saccular aneurysm that's in the circle of Willis. But occasionally it can be because of arteriovenous malformations or trauma to the head, which causes subarachnoid hemorrhage. So in this case, as a sidetrack, let's move on to, let me share my other screen. Okay, so Can you see my mouse moving?
Yep.
Okay, good. What can you see? Can anyone describe this picture?
I guess blood in the subarachnoid space.
Yeah, where is the subarachnoid space?
Is it the cisterns?
Yeah, the basal cisterns here. So just to orientate you, this is the frontal lobe. This is the this is probably, yeah, this is the basal cistern. This is the Sylvian fissure here. This is my third ventricle, my third coming to the fourth. And this is your temporal and your lateral horns of the ventricles, of the lateral ventricle, that is. And talked about Sylvian fissure. This is your sort of cerebellum, temporal lobe here. And sort of we are looking at a CT brain. So how I would present this scan to, let's say, a neurosurgical registrar is, I've got a patient, blah, 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 age, gender, and mechanism of injury, for example, falling off stairs or presenting from home with sudden thunderclap headache. And on CT brain imaging without contrast, the axial slides shows that there is frank blood in the basal cisterns and also the Sylvian fissure, with some signs of blood in the intraventricular space, namely the third ventricle. Other features may include, other features on the scan shows that there is some increased intracranial pressure. Obviously, you present that after you presenting your examination and your history findings, that is. And then you would say that I am worried that this patient may have a subarachnoid hemorrhage, or you can say it first to catch their attention. And could you please come down to review this patient for further surgical management, for example? Any questions on the scan? So if you see this scan, would you bother doing lumbar puncture?
I don't think so.
Okay. And what are you looking for on lumbar puncture?
I think from memory, the CSF has a yellow color or red color.
Do you know the name for that particular word that they like?
I think it ends with chromia, but I can't remember the name. Sorry.
Is that xanthochromia? Does that ring a bell?
Yeah. I think it's the yellowing.
Yeah, yellowish. That's yellowing of the CSF due to the sort of your metabolite of your red blood cells. You can also get increased protein, and that's from your red blood cell as well. Okay, so before the patient goes to theatre, what other investigations would you ask for?
Maybe a CTA.
Yeah, a CTA or a digital subtraction angiography, DSA. And basically that's for sort of your 3D reconstruction pretty much. And as you said, your CT angiography pretty much is very useful to identify one, where the aneurysm is, and second, how significant the rupture is, to identify the source of bleeding. So to guide the surgeons whether they should approach it with a clip or whether they should not approach it, and maybe palliate the patient if the bleeding is too severe, or usually not to palliate, but conservative medical management for the patient rather than surgical approach. For example, in an 80-year-old person with already sort of Alzheimer's dementia. So your CTA is very helpful there. And non-invasive angiography is usually done in high-risk cases. And those are sort of done when your CT or your LP doesn't really help you. So you really want a reconstruction to see if there's an aneurysm present or even an AV malformation present for more definitive approach. So let's move on to treatment. I'll go back and share screen. Can we see this? So management for neurosurgery. Okay. And they may perform sort of angiocoiling or stenting depending on the size of the aneurysm. Yeah, that's that. And one of the key complications of subarachnoid hemorrhage is a rebleeding risk, and it's the most likely sort of complication to occur after the first 24 hours. So in the first 24 hours, they are at a great risk of rebleeding. So we prevent that by maintaining blood pressure of less than 150 millimeter mercury. However, this is actually controversial because if you search up on Google, there's something called a triple therapy for subarachnoid hemorrhage, where they actually allow a permissive hypertension to occur together with hypovolemia and hyper something else until the aneurysm has been clipped or coiled. But as a usual guide, certainly with RMH, I know that the blood pressure is kept low with hydralazine to prevent rebleeding. And I think it was you, Ray, that said that there is a risk of vasospasm. So why is it dangerous to have vasospasm?
I believe it can cause stroke.
Yeah, you can cause subsequent ischemic stroke as a result of vasospasm. And do you know what days or when do you tend to see it after a subarachnoid hemorrhage?
I'm not too sure, sorry.
It's usually 4 to 10 days. So usually 4 to 10 days. However, the risk is there all the way along the subarachnoid hemorrhage course. And the reason is because the blood outside of the vessel is irritant to the vessel, and it causes calcium channels to basically cause vasoconstriction. And the way we treat it is we use nimodipine to sort of block that calcium channel conduction to reduce the vasospasm that we get to prevent any subsequent ischemic strokes. So we use nimodipine, okay? And what other things do we need to do for this particular patient? When you have blood in the interventricular space, what other things can occur?
Would you want to drain that blood that's already sitting there?
Yeah, if we go to theatre, we definitely want to drain any blood that's there. That is true. However, even if we've drained the blood, what's a potential complication of subarachnoid hemorrhage? Actually, there are two complications.
Hydrocephalus?
Yeah, very good. Hydrocephalus and also ventriculitis. So you might want some IV antibiotics for the patient. And also, to treat hydrocephalus, we may put a lumbar drain in. We may need a diagnostic and therapeutic lumbar punctures just to drain some CSF so that the patient's not increasing their ICP from the hydrocephalus. Or we can put in something called a ventricular peritoneal shunt. So all the way from the ventricles down the side into the flank, into the peritoneal space, which is commonly done as a result of treatment-resistant hydrocephalus or post-subarachnoid hemorrhage hydrocephalus that we think a VPS should be done. Any questions there? And of course, yeah, I've left it out, but also your usual interventions for increased ICP. So head up 30 degrees, institute hyperventilation, allow sort of your hypocarbia, administer mannitol if persistent increase in ICP, and sometimes we if you suspect that ICP will be increased after the operation, we can put an ICP monitor in, and if that's, let's say if it's persistent ICP, then we can use something called thiopentone, but that's more sort of your severe cases. Okay, what else did I have for you? All right, I'll quickly go because of time. I'm trying to finish it in 1.5 hours today. So I'll quickly talk to you about 2 more things. Let's talk about cavernous sinus syndrome. Cavernous sinus syndrome. It's usually from infection of central facial skin / orbit / sinuses, which leads to septic. Okay. And I've told you it's from the skin. So what do you think the most common causative agent is? Skin, Staph aureus. And what do you think, if I've told you Staph aureus, then what do you think the treatment is?
Antibiotics.
Yeah, antibiotics. Which one, Alex?
Do you use penicillin?
Yeah, very good. Penicillin, or I would say 3rd or 4th generation cephalosporin. So ceftriaxone or cefpine. However, if we do, actually, I'll talk about management later. So history, you want to take a history examination from every patient. So headache is the most common presenting complaint that is associated with, so this is your association questions in OSCE. So that's your orbital pain, your edema, your visual disturbance, yeah. And what else can I think of? Okay, and examination findings, you get fever. They tend to appear very ill. Is there anything else? Diplopia. And that's pretty much it. Okay. And if you don't act on them, they can deteriorate in the mental status, in that they can become confused, drowsy, and they can become septic as well, with hypotension and your acute collapse requiring met calls and stuff. Okay, so investigations. Anyone know the investigation for when you're suspecting a cavernous sinus thrombosis? Actually, I shouldn't say cavernous sinus syndrome, because that's another thing.
Maybe some CRP ESR.
Yeah, very good. So as we've discussed before, starting off with the bedside, anything that you can do bedside for this particular patient, probably not. Starting with FBC, your UEC, because we do need contrast later on. And then what sort of imaging would you want, Ray?
Maybe a non-contrast CT.
Yeah, so non-contrast CT. All right. So when the patient presents with headache, sure, non-contrast CT first, but after non-contrast CT, you don't find anything, what else would you order?
Would I consider contrast?
You would consider contrast, but are there specific contrast scans that you would want?
I'm going to guess maybe contrast MRI.
Yeah, so CT is okay. So you can get what's called a CT venogram. Have you heard of that? Yes.
No.
So with investigations, your CT, you can get an angiogram too, but you want also a CT venogram. Okay, and possibly an MRI venogram as well, just to assess the anatomy of the sinuses and to assess the extent of the clot. And what other investigations? Blood cultures is something that you want as well. And it's usually positive in 50% of the cases. So management-wise, let me just bring the table down a bit. So management, as Alex has said, penicillin, but you can go with triazone, caffeine. However, you can also go with metronidazole to cover anaerobic infections. Does anyone know why you want to cover for anaerobic infections? Because I've told you that it can come from sinusitis. It can sometimes even come from your dental, sort of your poor dental hygiene. So those areas can have anaerobic organisms, in which case you need metronidazole. And if you're suspecting MRSA, then you would add vancomycin. And in severe cases, when you expect fungal infections, then you add in. Okay. Usually it's a very long course of at least 3 to 4 weeks, I believe, of IV antibiotics for these patients. Very, very prolonged course of antibiotics because of sort of prevention of further infection risk and infection complications rather, and surgical drainage may be necessary if antibiotic response is limited within 24 hours. So IV ABS for surgical drainage if no response to ABS within. Okay, any questions on cavernous sinus thrombosis? And we'll move to the last but not least. Let me find it first. My acute angle closure glaucoma. So in a headache history, especially for the MD2s, acute angle closure glaucoma is often forgotten because people think that it's to do with the eyes, but in fact, it's a very sort of high yield red flag differential to rule out for all headache presentations. So I'll probably go with, because I know that some of you may not have much exposure of acute angle closure glaucoma, so I'm going to explain it in more detail in the last 5 minutes. So what is acute angle closure glaucoma? It's basically flow that's obstructed the anterior chamber, okay, which leads to increased intraocular pressure. And if you can all remember to your first year anatomy of that lovely diagram of the eye with the anterior segment, the posterior segment, and how the ciliary fluid or the aqueous fluid that's produced from your ciliary body is drained through the trabecular meshwork through the canal of Schlemm, that particular angle is disturbed. Okay, so maybe search up a Google image of anatomy of the anterior segment, then you will know what I'm talking about with the iris obstructing that particular meshwork or drainage system. Risk factors is pretty important to identify. Usually older age, people with a family history of AACG, people like me of the Asian background, they have hyperopia. And the reason with hyperopia is the particular shape of the lens can predispose to a more significant obstruction. And prolonged pupillary dilation. For example, prolonged time in the dark area in the COVID era. Stress medications can all lead to prolonged pupillary dilation. You can get it from anterior uveitis. So, for example, with HLA B27 syndromes, with sort of your colonic symptoms that's associated with the eye symptoms, you can get anterior uveitis, which can predispose you to more inflammation in the eye, causing obstruction of the anterior segment, leading to acute angle closure glaucoma. And you can also get lens dislocation. So, history of presenting complaint, usually, let's say, just making this up, 25-year-old, let's make up a name. Maybe Amy Todang comes into your clinic with sudden onset eye pain. Actually, with sudden onset headache, let's say, because it's headache tutorial. And then you do a regular headache history, then you think about, okay, Jason's giving a tutorial and saying that acute angle closure glaucoma is an important differential. Then you ask, okay, do you have eye pain? And yes, the patient has eye pain. Do you have blurred vision? Yes, the patient has blurred vision. Nausea and vomiting, yes, sort of asking you about the more systemic stuff. And you examine the patient's eye. What do you find? You find a hard red eye. Just by looking at it, not even grabbing your slit lamp out, pupils dilated. And what do you ask when you ask her what she does? She says she studies medicine, MD1 during the lockdown. And she basically spent the whole year at home in the dark room. Okay, you know that there's prolonged pupillary dilation. You're suspecting acute angle closure glaucoma, and the pupil is dilated and also non-reactive to light. So you can't really get it to constrict for some reason. And on diagnosis, you then diagnose her of having acute angle closure glaucoma based on the history and examination, and then you move on to a treatment. Okay, now I'm going to go off tangent for 1 minute. If you feel the eye, and if the eye is pulsating, what differential do you have? This is like extension.
Could it be an aneurysm?
No, it cannot be an aneurysm because it's usually not pulsating. It can be a carotid cavernous fistula. So in that case, you feel the eye, it can actually be pulsating. So I find that a pretty interesting differential when you see a red, hard, pulsating eye. as compared to this presentation. Anyways, let's move to treatment. It is a medical emergency, so you want to refer to ophthalm immediately, and that's probably one of the only time that ophthalmologist needs to sort of wake up at 2 a.m. Treatment is pretty much based on decreasing the intraocular pressure. So firstly, you would want eye drops. What eye drops do you have? You have beta blockers. So usually the one with the eye is called timolol, and pilocarpine is not a beta blocker. Muscarinic, I think it's a muscarinic agent. You want systemic treatments, so systemic medications. Does anyone know what systemic treatments you would give? You give something called a carbonic anhydrase inhibitor. Does anyone know the trade name? Not the trade name, the generic name for it? Starts with aceta and rhymes with zolamide. Or you can actually use IV mannitol as well to decrease the pressure as well. So similar approach to increase ICP. But for more definitive treatment, which the eye surgeons do, is a laser peripheral iridotomy. Because if you look at the anterior segment anatomy, if you get rid of the iris itself, it actually opens that angle and allows drainage to occur. And what they can also do is they can actually insert something like a shunt to create an alternative pathway to drain the fluid through to the venous system for intraocular pressure to be decreased. And if you do think that, for example, if a person has multiple risk factors, anterior uveitis, Asian, hyperopia, prolonged time in the dark because of the job requirements, you may give laser peripheral iridotomy as a prophylactic treatment to prevent acute angle closure glaucoma in that case. Or if they've had it in the past and somehow it resolved, you would actually give it as a prophylactic treatment too. Now, a lot of people think that you can actually give pupillary dilation to open up the angle, and that's a big no-no. So do not, if you don't take away anything, do not give any medication that causes pupillary dilation. And why is that? Because it actually closes the angle further, and it can increase the intraocular pressure furthermore in the acute phase, in the acute presentation setting. Okay. Anyone has any questions? If not, that is all I have for you today.